Welcome everybody at this new episode of European International Journal on Air. Today we have the opportunity to have with us Robin Leroux, the first author of a very nice paper about the outcomes of TAVI in patients with pure aortic regurgitation. Welcome, Robin. How are you?
Hi, Chiara. Thank you for the invite. I'm fine.
So thanks for being with us to talk about your paper. Indeed, very nice results about something that it's under discovery. So can you briefly tell us about the design of this registry and the type of population you included?
Sure. Well, we conducted this analysis in the French TAVI registry, that is a French multi-center prospective registry that involves 55 centers in France. We wanted to select the specific population of patients that underwent TAVI due to pure aortic valve regurgitation. So we selected patients with grade 3 or 4 AR and without any gradient on the valve. So we excluded the ones with a mean gradient greater than 15 millimeters of mercury. And then obviously all those patients that underwent the procedure were patients that considered at high risk for surgery. So that was based on the local heart team decision. And what we wanted to really focus on was to assess the contemporary results of this procedure in that particular population. So we focused only on the new generation devices that included SAPIEN 3 for the balloon expandable valves and mostly Evolut Air with some Evolut Pro devices for the self-expandable devices.
Okay, so if I understand, it's a population of around, I read, 200 patients, maybe more. So it means that anyway, TAVI in this patient is still a challenge, even because it seems to be a sort of off-label. So it's very nice to understand what happened with these new generation devices in this population. So which are the results that you found out from TAVI in these anatomies?
Yeah, so based on these methods, we found between 2015 and 2021, we found 227 patients that met our selection criteria. And so those were enrolled in 41 centers in France. Basically, our population is an elderly population, 81 years old, median age, with mostly males, around 60%. The Euroscore 2 Euroscore 2 score was 6%. We can perhaps discuss that later. But apart from that, they were highly comorbid with more than 50% of chronic kidney disease. 15% of them were in preoperative critical stages before the procedure that led to urgent procedures in those patients. And ejection fraction was low, around 46%. So basically an elderly, comorbid and high-risk population, as expected because of this off-label procedure, reminding you that surgery is still obviously the gold standard treatment for aortic regurgitation.
So, according to the quality of this population, that I understand is a sort of medium high risk, I would say. What did you find out? What TAVI resulted in for this patient?
Well, basically, concerning the procedure in itself, we found that, and those were like reflecting the current interventional practices that we have developed during the last year. So more than 90% of the procedures were undergone with the femoral approach. The devices were equally distributed between self-expandable and balloon expandable valves. There was a trend towards more self-expandable valve, 55% versus 45, but this was not statistically significant. And as I said, the balloon expandable valves were SAPIEN 3 and self-expandable were mostly AVOLT-R. The main findings regarding the procedure is that our primary endpoint, that was technical success defined according to the VARC 3 criteria, was 85.5%, which was mainly driven by the need for second valve implantation, followed then by that was the rate we reported, the incidence we reported was 8.8%, and which highlights the main issue in that specific valvular disease for those off-label TAVI procedures, that the difficulty of anchoring the device in the proper anatomical position. So that was an important finding. And then obviously we reported the other midterm outcomes, but basically the main finding that has to be mentioned is that in our population, the devices implanted were the largest one in most of the cases. More than 75% of the patient had a valve. The diameter of the device implanted was 29 or more. So when you know the different sizing, you understand that those were devices that we must implanted. And so this ended in part with a high rate of pacemaker that we found around 36% at 30 days, which is very high when we consider what we know based on the aortic stenosis field. And then those were the main outcomes at 30 days for in our study.
Okay, so if we have to summarize, indeed, the TAVI procedure can be safe in this patient, but the problem is the anatomy, because they require larger valves because of the lack of calcium for the anchoring. And so this can result, indeed, on one side in pacemaker implantation, but on the other side, if the anchoring is not the good one, in need maybe for a second device because of embolization of this first one. Did you report this data has related to some even long-term outcomes reduction, or?
Definitely. So what the very important take-home message from this study is the long-term and the midterm, long-term prognostic assessment that we provided. So basically, an important finding was that those patients that needed that second valve implantation, most of the case due to valve migration or embolization, those patients had a significant worse prognosis compared to those without this need in second valve implantation. And this resulted at the end to the fact that the technical success in those patients is critical and really matters in terms of prognosis. So this is an important message for our interventional community.
So a technical success of 85 is more than 50, but it's lower than 100. So maybe we are still far away from treating patients that are at lower risk, or maybe younger patients. So we agree that surgery in this case is still the sort of mandatory treatment. But we say that because we are using valve that we usually implant in aortic stenosis, so it's a different pathology. So do you think that maybe with device dedicated to the aortic regurgitation anatomy, we could improve something?
Definitely. So as you said, the off-label TAVI procedure in those patients is challenging because we're using devices that have not been developed for this pathology, right? So we end with having those complications that have an impact on prognosis. So if we can address this main issue, then we should be able to we guess that we should be able to improve also the outcomes for our patients. So in that field, we have two dedicated devices that are coming up. The one that has is more major is the JenaValve, and in the recent trial Align AR published this year, the technical success rate that was based on VAR2 criteria, so not the same, and the one with less criteria than the one we used. They reported technical success of 95%, so which is much better. And in fact, the EFS trial with the G valve reported also a 94% of technical success. So apparently, those data support the fact that those dedicated devices display a better procedural outcomes, and but they are also, at least for the JenaValve, they have also this main concern about pacemaker implantation. So we have to figure out how we can improve this outcome. Well, we have to. There are several hypotheses in that field, but probably that oversizing is the main driver for this complication. And so basically, we have a lot to learn about those new devices also.
So if we should conclude this nice talk with you, we should say that your paper, indeed, it's a sort of milestone, because it's a registry coming out from a very huge French registry, so many patients, but indeed this pathology is still less common than the aortic stenosis, so it's something that's important to know. TAVI in this patient is feasible, but pay attention, because with the device that we have for the aortic stenosis, we are in a sort of gray zone for the treatment, because we can achieve some good results, but we have to put on the other side the adverse events for this patient. So probably the dedicated device will change at least the need for a second valve for this patient, even if the pacemaker implantation still remains a sort of question that we have to ask ourselves before going for TAVI in aortic regurgitation.
Definitely.
Thank you very much.
I will just add something about the long-term outcome. We evidence that those patients, even if the majority of them have a successful procedure, successful intervention, they experience major clinical outcomes during all the follow-up and up to midterm follow-up. And so we have to also question the timing and the fact that those patients have to be referred in heart valve centers on time, and because probably that when symptoms and cardiac damage is too it's
advanced,
it's really advanced, then we even by fixing the valve we cannot
improve the quality.
Those patients remain at very high risk.
Okay, thank you very much for sharing with us the data of the paper and your personal point of view. It was very important and impressive for us. And let's wait for the next Euro Intervention Journal on Air coming next month. Bye.
Thank you, Chiara. Have a good day.